I said, good morning, everybody. እንኳን ደህና መጣችሁ. አማርኛዬን አልረሳሁም. But still, I would like to talk in English if you don't mind. It's really a pleasure to be back in Addis. I was here in November. Time flies, 5-6 months already. So back again with you guys. The good thing about being in a meeting is to meet old friends, but most importantly, really to get to know new people and make new friends. So hopefully we might be able to get to know each other today and be able to share our knowledge, learn from each other, and discuss whatever topics we have in mind. Particularly, I'm biased, of course, as a pain physician. We're going to be discussing about pain. With that said, my topic is going to be about pain management in advanced disease. Obviously, the advanced disease could be non-cancer related and also cancer related. Most importantly, for this session, I'm going to be focusing with cancer related advanced disease and how we might be able to manage those patients as far as their pain is concerned. So I'm going to be talking for about 30 minutes. And if we have time, either now or later on during the panel session, we're going to have question and answer period. The first thing which I would like to start with is always the red line, because a lot of people ask me, what's this red line about cancer? So one of MD Anderson's mission is to eradicate cancer. And we came really a long way in achieving partly of eradicating some type of cancer or trying to eradicate some type of cancer. We have progressed quite a bit in the area of melanoma treatment as well as lung cancer. So that's our logo for a few years now, just representing that our mission is to eradicate cancer, not only in Texas, but also nationally, as well as throughout the whole world. So that's what the mission of MD Anderson is. I don't have anything to disclose financially, but I do need to always show whenever I give a talk, all the responsibilities and roles which I have to play. That's just a requirement which I have to go through, but I do not have any financial disclosure to make for this lecture. My objectives are 3 as illustrated here. The first thing is really so that we are all on the same page to try to define what pain is about. Pain is not just simply writing pain prescription pills or doing some injections and that's the end of it. It's not. It's really a science which we have learned over the last 20, 30 years, probably by now, quite a bit just like any other field. And the thing about pain is it affects every one of us, whether we like it or not. If you think about a simple thing such as lower back pain, each one of you will have at one point lower back pain in your life. Again, that's just part of nature, I guess, whether we like it or not. So as a providers, healthcare providers, it's our obligation to understand at least the basic principle of pain management. You don't have to know details unless you are expert in that area and subspecialist in that area. But you do need to understand at least a few basic principles of pain management so that you are able to offer your patient population the things which they deserve, really to improve their quality of life better by reducing the amount of pain which they have, particularly those cancer patients who are terminally ill in advanced disease states. I also would like to walk you through very, very briefly about the type of treatment option which we have today in the 21st century. And most importantly, we'll go through the challenge and the opportunities which we have, particularly in this country as well as in Africa in general. So hopefully you will be able to understand at least part of that so that we have a good discussion. When we talk about pain in cancer patients, really the bottom line is we would like to make their quality of life better. You know, depending on the stage of the disease, the unfortunate population of cancer patients, they don't have too long to live. So it's our, I think, ethical obligation as far as I'm concerned to do everything what we can to make their life easy. You could certainly imagine and agree with me when I say that terminally ill patients, they have a lot of experience in fearing and building their fear and anxiety quite a bit for various reasons. Reason number one could be they know that they're going to be, dying. They don't have too long to live. So they worry about a lot of things, including losing their loved ones, being dependent on others and losing control over their life. But most importantly, if you ask those individuals what they worry about, you will clearly hear that they worry about their pain at the end of their life and the suffering associated with that. Pain and suffering on those patients go hand in hand. So it's very, very important for us to understand that and to do everything what we can to minimize and alleviate their pain, to reduce their anxiety and their fear, so that they have at least a better quality of life at the end of their life. So pain, as far as I'm concerned, is a very, very important thing to understand. Obviously, if I were to ask you what pain means to you, I'll get 100 different answers, depending on your background, your education level, your cultural background. So the type of definition which you will provide me or give me in pain could be very variable. Because of that, some 40 years ago, International Association for the Study of Pain came together, tried to define what pain means or should be, really. And they spent a lot of time trying to define it, as you could see here on the left side, the old definition, which basically says an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And I highlighted a couple of words, as you could see in blue and yellow, sensory, emotional, as well as described in terms of tissue damage. I did highlight it on purpose. The first reason is the word sensory. We came a long way since the 17th century to understand the physiology, the pathophysiology, as well as the mechanism of pain. Pain has become a big scientific field these days. As I said earlier, particularly in the last 20, 30 years, we really learned quite a bit about that. And I could say today that we are able to manage most of problems associated with the sensory component. What we still need to learn about and try to understand a little bit better is the emotional component. That's the reason we need a lot of help from individuals, providers who know a little bit more than we pain physicians about the emotional component of pain. We work very, very closely with our psychiatrist colleagues as well as psychologists to understand that better. With the current technology that's available, functional MRI particularly, we are able to understand certain areas of the brain which are stimulated and highlight to be able to define the areas such as amygdala, which might play a significant role in the emotional component of pain. And when I talk about the emotional component, I'm also referring to suffering. So if you look out on the right side, about 4 years ago, the same organization, International Association for the Study of Pain, spent over a year trying to revise the definition which they put about 40 years ago. And what you could clearly see is, again, highlighted a few words, but most importantly, if you focus on the blue one, the word or resembling, and if you compare the two nomenclatures, which are very, very similar definitions, however, the word resembling is critical with the newer definition of pain. The reason why it's very, very important is that with the previous definition, it was assumed that you do need to have certain type of tissue damage or certain degree of tissue damage in order to define pain. In other words, you cannot have pain without a tissue damage. That was the way they define it, which not everybody agrees upon, obviously. And fortunately, 4 years ago, the way they changed the wording to resembling, I fully agree with that word, because you do not always have to have a tissue damage to have a chronic pain syndrome. A simple example which we see really one of the most difficult type of chronic pain which we deal with today is the complex regional, so-called complex regional pain syndrome, which used to be called many years back reflex sympathetic dystrophy. And that type 1, there are two different types. I don't have to go in detail about it, but type 1 is primarily without any evident tissue damage most of the time. So that really fits very well with the new definition. So it's important for us to understand how to define so that when we talk about different types of chronic pain syndrome, we are really referring the definition of the new definition of pain, not the old definition. And last but not least, obviously, pain, as I said, is unique. The definition I gave from each individual is different. The way people behave to pain symptom is completely different. There have been many, many studies in the past done. If you compare different ethnic groups, for example, from the European culture, for example, if you compare the northern part of Europeans, the way they express their pain behavior is completely different than if you were compared to the southern part of Europeans, the Italians, the Greece, versus the Finnish, the Swedish guys, or the Germans, where I trained first before I went to the US. The way they express is different. It's important for us physicians to understand that. I'm quite sure even if you practice here in Ethiopia, most probably you will notice, if you listen carefully to your patient and observe your patient very carefully, the way different ethnic groups behave. The ones coming from the southern part probably versus the ones from the northeast, east or west could be different. So you really need to understand to take care of a patient as a whole, not just the pathology. So you are taking care of the human beings. It's very important as a provider to understand the person as a human being and not just look into the pathology or the disease and try to address it accordingly. So coming back to cancer, cancer is growing everywhere. The rate is exponential in some countries growing, obviously. Just to give you, not to bother you with a lot of statistics, but just simple data here, 40 million new cases were registered in 2012. If you look at it, in 6 years, 2030, that's going to increase by over 60% to 21.7 million. That's quite a big jump. And you should not forget the amount of death associated with cancer as well, too. It will increase by at least 50%. So the more we understand cancer, even though in different countries, again, and you could clearly see in the US, the rate of death from cancer is much, much lower, obviously, in the low 30%, if you calculate it, versus in developing countries, more than 50%, as I mentioned. Ethiopia I added here, and I really would like to know later on what you think about what I'm going to say right now. Based on the global can data in 2022, Ethiopia registered about 18,000 new cases and 54,000 deaths. The question which I ask myself is always, where did this number came from? Does Ethiopia has, and you help me, does Ethiopia has a nationwide registry or not? Yes, I do understand there is a registry from what I know from the Gorambasa Hospital. But the question which I'm posing to you is, does Ethiopia has a registry as a nation throughout the whole country? My guess is no. Please correct me if that's a mistake. The reason why I'm emphasizing that is the number which you see here might be very, very underestimated. A lot of patients might not be able or might not be able to afford to come to Gorambasa or other big hospitals around the country. They die before they arrive there. And they are all human beings, just like you and me. We should not forget that. So we really need to put our heads together and work together, collaborate. Her Excellency gave a wonderful message. It's about the dream which we all should have. collaboration to be able to help each individual, not just those who could afford to come to the hospitals. And those patients probably survive if they have the money to come to a good hospital early enough in their disease. Of course, the chance of surviving is higher than a lot of those who cannot afford. So as a physician, you always have to keep that in mind. I personally do every single day. And I'll tell you this afternoon when we talk about the fellowship, one of the reasons why we wanted to start the fellowship and what are the criteria which we are thinking about achieving that. And then later on in the afternoon, I'll talk a little bit more about that. Since we are talking about health cancer this morning, I just want to give you another data here about the 5 most common cancer cases in Ethiopia based on what I read. Breast cancer for female, obviously the number 1. In a lot of African countries, it's really the number 1, particularly in the northern part of Africa, eastern part of Africa, southern, and some parts of West Africa. Interestingly, in the central part of Africa, the most prominent type of cancer which you find is cervical cancer. For those of us who are interested in research, we could also pose the question, why is that? What's different about the Central African population versus the other parts of Africa? So you could look into a little bit of the genetic aspect of cancer if you are interested in research and try to filter it out. Maybe there is also regional difference here within Ethiopia. I don't have the data to share with you, but I'm quite sure if you dive a little bit into the different types of cancer based on the regions within Ethiopia, you will find some difference. So for those of you who are young providers who are interested in research, that would be a very good research topic to look into. And of course, the other types of cancer, thyroid and colon cancer is also very, very prominent. It's very interesting, the number of colon cancer increasing not only in this country, but also in a lot of other developing countries quite a bit. And if those patients see physicians, appropriate trained physicians, early in their disease, the chance of survival obviously is much higher than if they were to go and see their physicians in the late stage of their disease. So like any other disease, the earlier you interfere, the better chance you have for survival. And if you talk about the pain in cancer population, it's very, very common, particularly in the later stage of cancer. Here, just to give you some idea, one of the main reasons, in fact, why patients go to see their primary care physicians or general practitioners, as you call it here, is because of their pain. And during that workup, the physician might come up with a diagnosis of cancer. And if it's, again, early enough, they might be lucky to survive. So it's very, very common to have pain during the physician's visit. And if you look at the different types of cancer, there are certain cancers, particularly head and neck cancers, which seems to be very, very painful compared to the other type of cancers, such as lung cancer or even breast cancer, at least in the early stage. Breast cancer could be very, very painful in the later stage, particularly when it's metastasized to the spine. Metastasis to the spine is very, very painful syndrome, which we see in a lot of patients in the later stage of their life. And it's not that easy to treat. There are techniques which we use, which we have to talk about later on, how to address those issues, but it's not that easy. But I also highlighted in green here, cancer survivals. We think that once the patients survive their cancer, they are all done. They shouldn't be complaining about pain. They shouldn't have any pain, as a matter of fact, and that's not true at all. About more than 30% of those patients will have chronic pain syndrome. And most of those have a particular type of pain syndrome because of the chemotherapy-induced peripheral neuropathy. About 90%, 80% at least of those patients will end up getting chemo. And chemo could induce chemo-related neuropathy, peripheral neuropathy, as well as central neuropathy, which could be very, very painful, and the quality of life really deteriorates of those patients. So we have to keep in mind, surviving cancer is not just the end of the road and they are pain-free. You shouldn't be complaining about pain. Even though we came a long way, as I said a few times this morning, understanding pain and having a number of pain medications in different parts of the world, obviously, there are still the amount of pain treatment offer which we offer our patient population is inadequate, even in developed countries, even where we work in the USA for various reasons. I listed here a few of those. Obviously, as a layperson, fear of addiction is quite a bit as one of the reasons why people don't seek or don't want to get pain treatment. Education among providers is another reason. We try to educate our colleagues in other different fields about the significance of pain management. Obviously, pain affects not only the quality of life, even the survivorship of pain, of patients with pain could be affected. So it's a very, very important thing to understand and keep that in mind. So there are a number of reasons why our pain management, even in developed countries, is still inadequate. I would say probably 30 to 40% of pain patients, cancer pain patients, are their pain is adequately addressed. So we still have a long way to go, educating each other, educating our colleagues, so that we see the patients, so that patients are referred to us early enough in their continuum of their cancer treatment. Now, a lot of times when I tell people I work in cancer center, they think automatically I see only cancer-related pain, and that's not true. Cancer patients are human beings. They could have different other types of pain syndrome. So, and in fact, I look at our numbers here at MD Anderson. Every patient who comes through the door obviously has got a diagnosis of cancer, otherwise that patient won't come in to the hospital to begin with. But what's interesting is about 40 to 50% of our cancer patients within our clinic complain about non-cancer related issue. I mentioned, if you remember earlier, that every one of us will have lower back pain, for example, at one time in our life. Cancer patients could have that as well too. So we take care of non-cancer related pain issues as well too. So our fellows, our trainees are fortunate to be exposed to not only to cancer pain management, but most importantly also to non-cancer related pain management. So we have to keep that in mind. And there are a number of literature about that the fact that cancer patients could have non-cancer related pain. So we mentioned earlier that we came a long way understanding the basic mechanism, why cancer pain happens to begin with. The sensory aspect, we could take care of that because we understand the basic mechanism, what happens whenever you have tissue trauma, whether it's a mechanical thermal injury, and so on. There are a number of mediators which are released at the site of injury. Again, I don't want to go too much deep into that unless you ask me the question later on. But what's important to understand is there are peripheral nociceptors which are normally dormant in sensory neurons. But when you have any type of injury, you unmask the activity of those peripheral nociceptors through the release of many mediators. And we know exactly which mediators that are released as listed here, many of those. That means you could also imagine by just attacking one type of mediator, you might not be able to answer the question. You might not be able to address the pain issue adequately. So you really need to figure it out. What are the main players in initializing the so-called peripheral sensitization and address it depending on the stage of the pain, addressing accordingly. A lot of times you might not get away with just one type of treatment or one type of medication, for example, or one type of injection. You have to combine different sources to be able to address all this, or at least some of these mediators accordingly. The problem is not only the pathology stays in the periphery, but also it transitions to the central nervous system. So subsequently, what's going to develop is the so-called central sensitization. So the peripheral pathology will transfer to the central nervous system in the later stage. That's when things become a little bit more difficult because you have to address not only the peripheral mechanism, but also the central mechanism. Particularly earlier, I said that the emotional component, what's going on in activation of the different areas of the brain. We don't know too much. We know some areas which are activated. And we could target those areas, but only targeting specific area of the brain, again, will not answer the question. So you really have to play a double role. You have to target the periphery where the initial trauma starts with. At the same token, you have to address the central nervous system. So with currently available technology of diagnostic technology, such as fMRI and PET scan, we might be able to learn a little bit more where the activation takes place in the brain area and be able to try to address the issues in the central nervous system. So it's very, very important to understand the basic mechanism, where the pain pathology starts, where it's going to end up, at which level you might find the patient when they come to see you. It's not easy, but it's doable. And you try to address it in multimodal approach, not just one thing, targeting one thing. We also came a long way understanding the behavior, not only of the patients. We do have animal models, which we use in our laboratory quite frequently to be able to mimic the behavior of patients. This is just to show you an example of a rat which was injected with Taxol, which is typically given, as you all know, with the breast cancer patients. They almost all of them will develop chemo-induced peripheral neuropathy, which is very, very painful. It leads to numbness of the extremity. It also leads really to decrease the quality of life the patients have because they won't be able to do things which they normally do with the normal peripheral nervous system. Chemotherapeutic agents destroy those, at least part of those nociceptors in the periphery and later on the central nervous system. So we are able to mimic that the behavior the patients have on our animal models. If you were to pick them with different form filaments here as they are listed, you will be able to quantitate how much painful sensation the animals have and be able to utilize different experimental drugs, obviously, as we do, to be able to reduce their painful behavior of the animals, which later on our hope is to be able to transition that drug to the clinical scenario. And there are a number of drugs which have been developed using those animal models already. So what type of treatments are available currently for cancer pain patients? We all heard about the World Health Organization's ladder and the 3 ladders which have been around also for about probably 40 years by now. You'll be able to get away with about 80–85% of pain issues if you just follow the 3 ladders, which are highlighted here, the 3 bottom steps of the ladder. However, you might have 10–20% of the patient population who might not respond to your treatment by just following the 3 steps of the ladder. So we added the blue steps. We pain physicians added the 3 additional steps, as you could see, a little bit more aggressive interventional procedures, which we could utilize to be able to address those issues, particularly intrathecal injection of various drugs, particularly opioids, as well as intracerebral injection, neurolysis, and so on. There are currently available technologies. Some of them, of course, they are expensive, but others not so expensive, which one could utilize to be able to address those 10–20% percentage of patient population who do not respond to the 3 steps of the ladder from WHO. And there are a number of agents listed here, adjuvants, for example, which you could utilize in particularly those patients who express the so-called neuropathic pain syndrome when they come to see you. So it's a combination of a number of drugs, really. It's not just one simple drug to address the issue. Because again, if you remember of one of the slides, I mentioned the number of mediators which are released, both in the periphery as well as in the central nervous system. So understanding the basic pathology, pathophysiology, and the mechanism of the disease, if I call pain as a disease, is very, very important to be able to address it accordingly. I listed here typically, for example, the so-called neuropathic pain syndrome associated with cancer, how you address it. And there are different criteria, different guidelines out there. Obviously, each one of us who have been around in the area of pain management for a long period of time have got our own way of tweaking around those guidelines. Guidelines are not written on stone. Those are just recommendations that you could follow or you don't follow based on the evidence, obviously. And sometimes you might be able to tweak them a little bit around, as I have done here for my patient population at least, how I would address neuropathic cancer pain syndrome. Because if you think about cancer patients, they are already on 100 different drugs by the time they come to see you. And if possible, you don't want to add some more drugs. Sometimes you don't have a choice. But if you have a choice of avoiding additional drugs by offering patients, whether it's interventional procedure or simple other methods of treatment, I think that's preferable. And that's why I choose as the number one first line of drug, for example, as simple topical agents. Lidocaine 4%, 5% seems to work for a lot of neuropathic pain syndrome if it's only localized peripherally. You remember I said over time it progressed to the central nervous system. And if it does, obviously it's useless to use the topical agents to address the central nervous system. You might get away a little bit by addressing the peripheral pathology by using topical agents. So you have to understand where you are, the type of patients you have, at what stage of their disease you find the patients. And then the rest of the second choice and third choice, as I listed here. The bottom line is you have to understand the stage of the disease meaning pain in this case, and be able to address whether you would like to address the peripheral mechanism of the central, or a lot of times a combination of both. And in order to be able to do that, obviously you have to learn and you have to know about pain. So we collaborate very, very closely with our colleagues, particularly neurosurgical colleagues. Here are some of the examples of interventional procedures we, as the pain physicians, offer our patients. Again, some of them are very expensive and some of them are not expensive at all. And the neurosurgeons accordingly could help us, in fact, addressing some of the pain issue, particularly those if the pain is centralized and would like them to intervene in the brain area. For example, doing cingulotomy or cordotomy or deep brain stimulation and so on, they will be helpful a lot of times. So it's just working together with other disciplines and not just work by yourself. You know, you have to have a multimodal approach, multidisciplinary approach to be able to address the issue accordingly. So today we have a lot of options to offer to our patient population. If we understand pain, in which stage of the disease the pain is, we find our patients at, to be able to target it appropriately. Obviously, a lot of times we don't talk about some other therapy opportunities and which we could offer our patients. I listed them over here. It's very important, even for those patients for whom we choose interventional procedure or drug treatments, we have to combine to make them functional, to restore their functionality. Physical therapy is a simple thing, but very, very important thing to address in the early stage. As soon as you have the pain under control, you need to make sure that the patients do physical therapy, occupational therapy, and other treatments as well, as listed here. So again, I just want to emphasize that it's not just one thing, it's a combination of treatments which we need to offer our patient population. which they deserve that. A lot of times we might use treatments such as, in fact, we have an NIH grant right now going on with acupressure and acupuncture. It could be very helpful, but it's not like anything else helpful for everybody. So you have to figure it out which type of patients might be appropriate to prescribe or at least to try that type of treatments. And there are certain criteria which we look into in order to be able to achieve that. Early, when I started my talk, I mentioned about the second slide, I think, about the fear which these patients express with. Fear, anxiety, and obviously sleep deprivation associated with that. They all go hand in hand. And when I say we need to address pain in the peripheral nervous system, in the central nervous system, again, we should not forget to address the fear issue and the anxiety. Sometimes, if we are lucky, just by addressing the pain with appropriate treatment, we might get away without addressing individually the anxiety issue or the sleep problem or the fear which the patient might have. But a lot of times, particularly in the later stage of their patient's disease, you might need some help from your colleagues from psychiatry to be able to help you with the anxiety aspect. It could be, drug treatment. It could be some other treatments. So behavior modification is another treatment which they offer our patient population. So in other words, the message here is really, do not focus just on one thing, pain. Give pills, do the injection, and that's it. You have to really know your patient's background, the social background, the family background. I prefer to see my patients coming with their relatives, husband, wife, children, or whoever that might be. It's very important. In fact, a lot of times when they come, they are so frightened. They don't tell you all the story which is important for you to know about the patient. So family members could be very, very helpful. So always be observative, observe what they do, how they say things, observe most importantly what they say when they say. You could learn a lot about the patient and you could address their fear, their pain issue better that way and just not focusing on the pain alone. So cancer, a lot of challenge, obviously. I just listed here a few of those challenges in developing countries, obviously. Things are evolving, things are changing, even here in Ethiopia. I remember a few years back when coming here to teach with a couple of my friends, which we used to hear from our colleagues from Ethiopia, is that the number of, my background is anesthesiologist, the number of anesthesiologists here in this country, a few years back, I was told were 33 only throughout the whole country. Now I've heard, the last time I was here in November, I've heard there were more than 100, I think 130 or so anesthesiologists around the country. So things are improving. Obviously, there is also a migration of anesthesiologists, I'm sure in the other field as well, to different other countries. Whether that number is going to stay that way, I don't know. But what I do know from what I hear is that the number of trainees has increased quite a bit as well too. So hopefully we'll have more physicians in the country, more young generation of physicians who are eager to learn. And being a pain physician biased, I hope a lot of young generation of physicians will look into going to pain medicine, hopefully. And hopefully in the afternoon, we'll talk about that in detail. Dr. Capeta gave me 5 minutes more to go, so I'm going to hurry up a little bit. So challenges and opportunities here. One of the challenges which we see in terms of patients is that access. I mentioned earlier that those who have money, who can afford, could have access anywhere they want to go, whether within the country or outside the country. There are a lot of people who cannot afford that, might not have that opportunity, so they don't have that much access. So we need to do something about that. The other thing which I highlighted here is the really are the physicians, the healthcare providers educated enough addressing the need of the patients, in this case, pain patients at all or not? The answer is, I don't think so. So that's why we need, that's part of the reason why we need, experts in the field of pain medicine so that they are able to help their patient population. This is an article which I saw just recently, really published in The Guardian, as you could see, July of last year, it's less than a year, about the availability of morphine, how people suffer and die. Less than a year, really. And I'm told for different sources that morphine is available, but when you ask further, where is that available? The answer is almost always in big hospitals. And even in those big hospitals, when you ask further who is using it, I hear quite frequently that the availability of morphine in big hospitals, but people not knowing how to use it appropriately. Again, I'm mentioning that for us another reason why we need education, educating our colleagues so that they know a little bit about pain and they know a little bit about how to utilize the medications, which could be very, very beneficial for cancer patients, how to use them appropriately. So again, I'm advocating for pain fellowship in the pain field. So hopefully to be able to get the opportunity to collaborate and work with you guys to be able to address utilizing, strong medications such as morphine and its derivatives. It's very, very amazing to think and see how much of controlled substance, particularly opioid substance, are available in developed countries versus in developing countries. About 1% of morphine is allocated to developing countries throughout the whole world, while 95% to 99% of that is utilized in the US alone. It's no wonder that we have our crisis, opioid crisis, which have been on media day and night a few years ago. It hasn't, it has calmed down a little bit, but we still hear about them. So I just want to show you that in media, it was all over the place. A lot of crisis, people abusing, overutilizing. Addiction is a big issue even today, a very, very big issue, which we have to be mindful. That's why you have to understand how to use it appropriately for the appropriate patient, for the appropriate indication of the disease. With that, I'll conclude by saying that pain treatment is humane. We need to learn about it. We need to address for our patient population, particularly those who deserve most, the cancer patients, because their life is too short for them. And you need to make sure to be compassionate and help them so that they have a little bit of better quality of life at the end of their life, really. So with that, I'll stop, and I hope I have convinced you the significance of cancer pain management, and hopefully we'll be able to get some questions and answer period later on. Thank you very much for your attention.